So thank you very much. While the panelists settle, we'll just give an introduction. So both of us have decided to uh, alter the sequence of presentation, and we are trying to club the studies which have related content together, and we'll take turns to discuss those studies. So I'll start with the study which was presented by the last speaker of mammographic surveillance, where they did two yearly mammogram after 3 years of BCS and 3 yearly mammogram after 2 years of mastectomy versus annual mammogram. And results were presented. There is no change in breast cancer specific survival, overall survival, or recurrence free interval. It did save money, but did not save them from stress. The stress levels were actually the same in both the groups at around 25%. So, my question to the panelists, and I would like Dr. Vinita and Dr. Neeta to take this. What is your current practice of surveillance? Is it different from BCS and mastectomy?
So Vedant, the current practice of surveillance is
Um,
an annual mammogram. But I am quite influenced by this study, and I think it makes sense, to not have mammogram every year as shown by this study.
so, which group of patients?
So both for BCS as well as patients undergoing mastectomy, irrespective of stage, I think the frequency of mammogram can be reduced. It can save some resources, and I think would save some trouble also.
So, all patients, LABC,
Also.
EBC.
I'm going to disagree a little bit just because I would think that currently, yes, all of us practice an annual mammogram. For a mastectomy group, you're talking about a contralateral mammogram. That risk is about 1 to 2% per in their lifetime. Yes, that's an option. You know, the data seems very promising there. But I'm going to say that it's going to be different based on a lot of factors. Is she BRCA positive? What is the surveillance? What was the original stage we started with? We're going to look at all those factors. And for someone with a breast conserving surgery, I
So
would
can I
rather,
just
I'm
interrupt?
not
Although they have
very
not mentioned about BRCA,
so that's
I'm
assuming that
presuming that
everyone's
they have
BRCA negative.
excluded. Yeah, they've
And the
excluded it.
other thing
Yes.
that I'm going to say is we've been listening to abstracts talking about de-escalation of radiation, de-escalation of
We'll come to
axilla.
that later.
We can't do de-escalation of everything.
So any other panelist has a different view? One person wants to de-escalate on surveillance, the other person wants to continue the same.
Dr. Vedant, I would like to continue with at least annual mammography. What I would say, the de-escalation probably in the non-mammography investigations, which are actually being overused quite a lot in our setup.
Yes.
And the patient profile between the West and India, we are still, I think, totally different patient profile.
And also, this surveillance is basically a screening for another cancer. So, is this follow-up duration adequate for a screening kind of situation? Probably not.
Probably not, but I think most of us still do that. You do a mammogram once a year for the first 5 years, and then you do go to a 2 yearly mammogram. So that's not very different.
Okay,
Especially
moving.
young women where clinical exam is also not very sensitive, is dense breast, and if you are not doing mammogram frequently, it is
So the problem is mammo is also not as sensitive.
yeah, but at least it will complement.
Yeah,
It is
you
not.
then need to complement with ultrasound.
So,
Yes,
Dr.
Dr.
Vedant, just
Shalaka.
one thing. We
Yeah.
also had this thing about doing a lot of follow-up mammographies in our hospital, and we looked at what is the yield of this, like how many cancers do we really pick up, and we also wanted to actually analyze how many of them are also clinically palpable. That you can just pick up on clinical examination. So one of our fellows looked at 6,000 mammographies done in 6 months. So we did 6,000 mammographies in 6 months of follow-up. That's a lot of burden on the radiology department to report, and there were 23 23 abnormalities that were detected. Some of them did turn out benign, and I think we picked up 17 cancers. So we do need to give it a thought with respect to the constraint on the healthcare resources.
Yes.
What we need to do.
Anybody doing more frequent mammograms for conservation surgeries? More than annual? No. Good. So we move on to the next one is surgical treatment of women with cancer and BRCA1 mutation. This is a comparison of or impact of bilateral mastectomy on survival. Is a cohort of 2,400 patients across 11 countries, and what it shows is contralateral breast cancer is no different whether you do BCS or unilateral mastectomy. Obviously, it is much higher as compared to bilateral mastectomy. When you go to see the mortality, it is surprising that bilateral and BCS are same, but unilateral mastectomy has a much worse survival. So, how do you interpret this, Dr. Goyal? You want to take it? Yeah.
I think basically it's a retrospective study. Patient allocation is based on the choices. So the patients who went for mastectomy in this study had a totally different disease profile, which should explain the higher
Yeah, so
mortality.
you are right, and that's exactly the point. You see the unilateral mastectomy group patients, they have a higher stage, they have higher nodal positivity, so obviously we expect it. And that is why authors have refrained from concluding anything comparing bilateral and unilateral. They have just said BCS and bilateral have equal survival. And some of them, in fact almost 19% of them, did not receive radiation after breast conservation. That's also a little surprising. And all other adjuvant therapies also were quite heterogeneous. Now what we want to discuss again here is, they have also mentioned breast cancer mortality by contralateral breast cancer, and those who developed contralateral breast cancer had double the mortality. Yeah, Dr. Goel, would you like to comment on this?
So basically, I think a second new breast cancer developed. So that did have an effect on mortality. So we know that once a new cancer develops, it is likely to have some effect on mortality. So in that sense, it is not a randomized study. So we do expect.
So yes, what we have always known is mortality is not affected whether you do BCS or you do bilateral mastectomy. What they are trying to say is only for those who develop the contralateral breast cancer compared to the other group, it is increased. But as a whole, it is not. So it is safe to continue with BCS. Any other thoughts from any of the panelists? Yeah, after Shalaka.
No, my concern with a study like this is when you are asked, once you put that, when you tell a patient that there is an option of bilateral mastectomy, once that thought is out there, it's in that patient's mind, the bystander's mind, it's not easy for them to take that decision. We have to be very careful when who you tell this to. So they've included patients from stage 1 up till stage 3, and just by this study, I would not recommend this to all patients. Maybe a patient who's on the higher stage, maybe a patient who's going for a unilateral mastectomy, patients who will be needing radiotherapy because of a higher nodal burden or any other reason. For those patients, maybe you can suggest the bilateral mastectomy, but for the stage 1 cases, even if they're BRCA positive, once you give that suggestion to them, they're already very much scared.
But
Once
that
you give,
option has to be given. You can't
once
not
you,
give that option.
So I'm going to say just one thing on that is your patient deserves to have all the information.
Yes.
The discussion on the risk beyond that, probably actually for someone who's an advanced stage, I tell her wait a few years, see how the biology of this disease is before we discuss prophylactic options. But I would want to give my patient the information.
Yeah. Second from the last. You also wanted to make a point here.
Yeah, it was something similar that even though the prophylactic resulted in lesser contralateral breast cancer, but it did not result in a lesser overall survival. That is also an important
So that's
point.
the point. That's the point we have to put across and let them decide. We can't not tell them about bilateral mastectomy. We have to.
Thank you very much, and again, thank you, Year in Review, for your invitation. I'll just go back to this previous slide, and I have a bit of a contention. I have a bit of a difference in agreement, and I entirely agree with Neeta on giving patient the information. Would you all like to think if anyone is giving the information that okay, fine, you have a conservation surgery, don't go for bilateral mastectomy, but then if at all you develop a second cancer in your other breast, you have twice the chance of dying. That information, what would you decipher out of it?
Firstly, I think we should clarify that it is only breast cancer specific mortality which is double. The overall mortality is not affected. So we definitely
Well,
have
we
to.
don't know. The overall mortality
No,
wasn't reported in this
actually,
study. It's the
we
breast
have gone
cancer
through the
specific
whole
mortality.
abstract. They mentioned about the overall mortality also that was comparable. So the thing is, patient has to be given both sides of the information, and the job of the doctor is not to push the patient towards any particular option. Just give it in a fair and transparent manner.
Shalaka.
Yeah, so one thing is, yes, I do agree that the mortality, I mean, the risk of dying seems to be higher, but you go back to the slide previous. The incidence of, no, it's not there, but it's there in the original one. The incidence of contralateral breast cancer is 10%. So in 90% of patients, you would have overdone the bilateral mastectomy.
The way someone would look at it
It's
is it
actually
is 10%. 10%. 10 out of 1 out of 10 patients will get a second cancer, and if they develop it, they have twice the chance of dying. I'm sorry, it's not. It's something that you can think of. It's sir, no one knows. It's a retrospective study. I think sir said
It's not.
it's a single
Yeah.
retrospective study. You wish you know that, I hope that was as simple as this. We'll go to the next. I think it's a bit more interesting in the next one. Look, this is basically someone who's had a breast conservation surgery with a BRCA1 and BRCA2 mutant tumor. And these patients, you're actually following them up with a radiotherapy. So breast conservation surgery, radiotherapy. And then you report that you have a 140% chance compared to the control of having a second cancer if you get radiotherapy. Now, I'd request my radiation oncologist to look into this and comment. Tabassum, can we come to you at the end? Anyone else?
Second from left, I'm Dr. Revti. So I did go through the study. There is not much information about the dose of radiotherapy received or the technique used. So all these are quite old studies where the technique was not very modern. Even in fact, it's mentioned that in IMN irradiation, the right-sided cases received 10 gray mean
No,
dose.
ma'am, we're not
Yeah.
talking about IMN. We're just talking about
Yeah,
breast
so
radiotherapy
no,
in
I'm
these
just talking
patients.
about what is given in the paper. So there is not much information on the technique or dose used, and there is not much information on whether these recurrences were in the medial part of the contralateral breast to establish a dose relationship.
Yeah, so
Dose effect
my
relationship.
question
Yeah.
is exactly that, Sanjoy. I'd ask the radiation oncologist, would they interpret this data differently for different quadrants?
Yeah, coming.
So I think this data does sound alarming. We cannot completely ignore this. So the risk of contralateral breast cancer does seem to be higher in the arm receiving radiation therapy. It is a matter of concern, although we agree that the information on the dose to the contralateral breast and the quadrant in which the contralateral breast cancer occurred is not mentioned, but it does sound alarming.
So,
I think basically one thing we have to realize is that the radiation which was given, if the benefit of the radiation is good enough to justify, then we just have to look at the means of reducing the effect on the other breast by, I think, the
so how
technology.
would you reduce the
No,
of
I
the?
am not a radiation
Yeah,
oncologist,
so
but
can we
with the
just have the
current
radiation
technology.
oncologist then comment on it, please?
So even with the best of technologies that we use, and even when there is an awareness to reduce the contralateral breast doses, some amount of dose does go to the
So what is
contralateral
your? I mean,
breast.
I'm coming to that. I mean, now coming to you, Tabassum. What is the dose to the contralateral breast that you would agree to have?
Less than 1 gray.
Less than 1 gray. So it's
Up
if
to
you look
1
at
gray,
scatter
I would
radiation, when
say.
you're giving a high dose, having less than 1 gray can
But
be.
it's not true for, it's not achievable for patients with medial quadrant tumors. So, broadly, I mean, if you
So coming
treat
to
all
the
patients.
thank you, and coming to the issue about patient being empowered with the data. Do you think this data is something you'd share with the patient? Is this data which is mature enough? That if you have breast conservation surgery, and surgeons please look out for this interpretation. If you have breast conservation surgery, if you have BRCA mutant, BRCA1, BRCA2 tumors, and if your radiation oncologist gives you radiotherapy, you have 140% chance compared to the other patients who don't have radiotherapy of having a second cancer.
I just wanted to make a point that patients who have BRCA mutation, they inherently have a higher chance of contralateral breast cancer. So there can be a
No, ma'am.
confounding.
It's with regards to the control. The control didn't get radiation, and this is with radiation. Yeah. So sorry. I mean, it's just what that has been reported at 10 years. It's not even 20 years. It's 10 years, less than 10 years median follow-up. And then in the previous study you saw that if you develop a second cancer in the contralateral breast, then you're at twice at risk of dying. Just think about it. Yeah.
Louder.
Fantastic. Yes. So, if you have mastectomy for locally advanced tumors again, you'll get radiotherapy, and the risk, well, you can't really avert that risk because, you have to give radiation if you have a locally advanced tumor. It's only in the ones who choose to have conservation surgery and radiotherapy that you can possibly say that, could you have had a mastectomy to start with?
There's another point that after a certain point of time, patients started opting for prophylactic contralateral mastectomy, and that has affected the follow-up and the numbers at risk.
Fantastic. You've brought a very important point. This study is actually biased. It's biased because, you have these patients who had a contralateral mastectomy anyway, even after radiotherapy. So they used a statistical adjustment. So used a competing risk adjustment to try and account for those contralateral mastectomy. That's number one. Number two, we don't have any dose data. We don't know. We don't have any quadrant data as to where the recurrences were. So I do not believe that this data is rich enough for patients to actually make an informed choice when doctors over here are actually varied in their judgment of this abstract. So I think it's something that we need to see and possibly get a full text view and follow up further and then decide on patients deciding on their choices.
But still, I think the message is to be more mindful of the contralateral breast doses,
So surgeons, again, more mindful of the contralateral breast doses, radiation oncologists, surgeons, would you go for mastectomy straight away?
There's some data emerging on the use of radiation for prophylactic
There is,
tumors.
yes.
So how are we interpreting that with
Well,
this?
once the
then?
data comes out, we'll know.
When you're yeah, so when you're talking of choice, are you saying that we should tell the patients to go for mastectomy rather than
So
BCS?
I'm not telling you anything, sir. I'm just saying that these are the controversies, and we as experts, how would we decipher? I think if we don't agree, just imagine this poor patient with a BRCA-positive tumor coming into your clinic, and then you thinking, well, look, have mastectomy, have breast conservation surgery. What do we do with radiation? Possibly you need a consensus guidelines from India on this.
So it's interesting. This one has a higher risk of contralateral breast cancer, but survival is good. Survival is equal. The previous one we were discussing contralateral breast cancer, and then survival is poorer.
Okay, I think this is something that we all, as breast cancer oncologists, would see a paradigm shift in our treatment plan. The Lancet 2023 meta-analysis of regional nodal radiotherapy presented by Dodul, I think you presented it, was very nicely done. It shows that you not only improve with regional nodal radiotherapy, you not only improved with local control, which we know from older times, yes you do. With the current regimes, you actually improve overall survival with regional nodal radiotherapy after you treat locally advanced tumors. Now, I would request my colleagues over here to, I know that, we'll have a show of hand, but what is the current practice? Can we just have a show of hand of, how many of your surgeons would treat internal mammary chain, supraclavicular lymph nodes prophylactically in the adjuvant settings? How many of you would treat that?
Only one. One.
Oh, everyone. I mean, why just surgeons? Treating by radiation. Do you treat IMN by surgery, sir? I mean, yeah.
Supraclavicular.
Yeah, I treat.
So, as a MDT, how many of your MDTs would actually treat IMN prophylactically? One?
Yes.
Right. Okay. So now we've got a task in hand. Now, will this data help us change our view on treating with regional nodal radiotherapy? Again, Tabassum, I'll come to you at the end. Someone else as
this is a meta-analysis. It clubs all.
Sir, I mean,
He's a surgeon. He's a surgeon.
yeah, or madam, yeah. Okay, so you, ma'am, yeah.
I'm from RCC Trivandrum.
Please.
So our practice with IMN nodes is we treat it only when they are clinically positive, clinically
Yeah, that's
involved.
what it was for most of us quite some time back. But is this data strong enough? Anyone who can actually say, well, look, I think this data may be strong enough.
Can I just comment? Although I'm not part of the panel.
Dodul,
Dr. Chatterjee.
Yeah, those.
So because this article is almost a 15 page with another 55 page
Annexure,
appendix.
yeah.
So there are so many things written in that appendix. So they have also commented that the hypothesis, which we all know that central quadrant and medial quadrant tumors, they actually should benefit with prophylactic IMN therapy, and I actually practice.
Yeah, there is. Just hold on. I'm not saying you're wrong in practicing. I do the same. But let's try and decipher the data.
Can I just
Sorry, yes, sir.
segment the question a bit? I think we should, when we are talking of regional nodal irradiation, we need to separate axilla
So you're right.
from
So you're right. We're
supraclavicular
coming
from
to that.
internal
So
mammary.
please be patient. We are coming to that. Yeah. So regional nodal radiotherapy. Radiation oncologist. Yeah.
So we at Just Look also we are treating the central and the medial quadrant tumors. We are treating.
So
the
any
IMN.
central medial quadrant tumors, you give IMN radiotherapy to. Okay, something that can be a bit different. Vinita?
So everything comes with a cost. IMN radiation also comes with a cost, with some incremental dose to lung and heart, So I think in my practice, we do not do it indiscriminately for all central and medial quadrant tumors. We don't do prophylactic IMN radiation. And in the today's era, when we are doing a lot of imaging, a lot of patients have three-dimensional imaging. We have more information when the IMN lymph nodes are
I can
actually
see your
there.
perspective. Okay. Now,
I'm not a radiation oncologist, but I have just one comment that since last 50 years we have been talking about inner quadrant tumors doing worse, or inner quadrant tumors having higher chance of internal mammary lymph node positivity, whether you treat it surgically or you just do one offhand biopsy sometime or the other, but we need to treat it. I think a 3% benefit is good enough to at least give it a consideration to treat. But yes,
so
I
now,
understand the
we are
cost
seeing
and side
surgeons
effect
pushing for it,
analysis.
and I think, Tabassum, I think you really need to
There-
decipher this puzzle.
So sometime back, I had read an article which talked about medial quadrant tumors having node positivity in
Yes,
the
I think
internal
you're right.
memory
So let
if the axillary node was
yes,
positive.
sir. We're coming to that. I think, Tabassum, can you please?
Yeah, so I think when there is node positivity, especially high nodal burden, as the data shows that it is around 5% benefit in the highest benefit is in the four and more nodes positive. So IMN radiation is actually not very easy, but if you are able to give it safely, that's the one thing that you have to take into account. The techniques which must have been used in these trials would nobody uses these techniques nowadays. We have a lot more sophisticated techniques, and we are able to contain the dose to the heart better. The other reservation about this trial of this EBCTCG is that these are the systemic therapy is way better now. I mean, we cannot. I don't think we will be able to achieve the same magnitude of benefit in 4-node positive, because I think these are all pre-taxane era data of
The newer trials actually did use
2000
taxanes.
until 2008.
Yeah, so they did use taxanes,
So the
and
systemic therapies have
further escalation has
further
happened. Yeah.
advanced after that. So you cannot be, as rightly mentioned by Dr. Vinita, you cannot be leaving it left right. You have to obviously choose, and patients having more than 4-node positive and as well as if it is a medial central quadrant, then there is worth considering.
I think
If you
your
could
point of being number one, you have to choose your patients, and how do you choose your patients? That's why we've come to IIR, isn't it? How do we choose our patients, and when do we decide about the radiation? If you, sorry, yeah, we'll ask Anushil to comment. Anushil, yes, definitely.
The sense of the panel is quite right. I don't indiscriminately treat internal memory. And one of the reasons also is that we have seen, like in the auxiliary trials, that if you are leaving some disease behind, as the apprehension is for internal memory, it doesn't always translate into recurrence and detrimental in survival.
Yeah.
So that is
Anushil,
also another point.
how would you, I mean, I'm just playing devil's advocate over here. You've got a 3% improvement in breast cancer survival, a 3% improvement in overall survival.
See, the problem is that you have not been able to dissect out again in this
No,
study
you have.
what kind of benefit that you are accruing from
the
each
current
radiation,
TBC-TCG you
internal
have,
memory,
I think we,
or only
no,
SCM.
I think
So
the current
that
TBC-TCG
dissection
you
of
have.
each component is not there.
No, I think the current TBC-TCG you have, and that's where the supplemental data and this actually forest plot comes in, where you can actually see that it's not just the bigger tumors that get more benefit, not just the N2, N3s and the medial quadrant, but look at this. Patients who are having IMN, SCF and axilla, patients who are having SCF and axilla versus patients who are having IMN only, you're getting a similar benefit. Whenever you're leaving out the IMN, your benefit is actually less. If you're leaving out the IMN, your benefit is actually less. So I have been a proponent like you, that, are we actually going to prophylactically increase more toxicities? This meta-analysis...
Please balance it with the issues that you come up with planning, with the contralateral breast dose, and we have just seen what is happening with
now we are going to a
dose.
different aspect altogether.
No,
The
it
first,
all has to be taken together. How can you just take one component and leave the rest of the components?
The first point to agree on over here is whether the meta-analysis actually shows that IMN is beneficial. If we say yes, then the question is, can we actually balance out the toxicities? Yeah. Now, you're absolutely correct that the previous studies could not balance out the toxicities. That's why we had a survival disadvantage, the older studies. The newer studies with less dose to the cardiac organs actually does seem to balance out the toxicities. But saying that, these are studies with very strong quality assurance, very rigid hard dose. So the question then comes is, if you have a patient with locally advanced tumor.
So Sanjay, I asked you the question now. If you have a patient with locally advanced cancer and axilla has been dissected, what is your recommendation based on this thing? What portion of the regional nodes
So
will
it's
you
not
take?
just my recommendation. I mean, just like we are discussing this,
Yes.
There have been multiple consensus groups that have
Yes.
discussed this.
Yes.
And we all, and even me reading this data, this is how we've changed practice over the last 6 months. Bigger tumors, T3, T4 tumors, N2 disease, or medial central quadrant tumors, like Dodul says, if you read the supplement, it very clearly, there's a very clear evidence that medial central quadrant tumors with N1 disease, the benefit of IMN radiotherapy is clear. Now, that comes at a big risk, if you are irradiating contralateral breast, if you're irradiating contralateral, if you're irradiating the heart, these are risks you need to consider. So your radiotherapy has to be commissioned appropriately, which I think Anushil, Tabassum, and most of you here, if you have good quality assurance, I think that can be done.
Whatever quality assurance one may do, with photon-based radiation therapy, once you're trying to do IMN radiation, the dose to the contralateral breast as well as heart and lung does increase. And as far as when Tabassum said safe radiation, we still do not know what is safe. We know it has to be ALARA
ALARA
principle.
is safe as low as reasonably possible. So it's the benefit. So just imagine.
So Sanjay, one last point, that obesity meta-analysis is fine. But if you look at the trials, the actual randomized trials that have been done, I mean, you can't just ignore all the trials that were done beforehand.
How can you ignore? I mean, look at the Korean study that came up. The Croc study
the
was
URTC trial or the other trial.
No. The URTC trial has been included in this
Has been
meta-analysis.
included, but what did that trial say?
And
You
the
can't
Croc.
just brush everything off and
So
now
four-
say that this is a mix and a mixture of so many
I
things
think
that
this
they
is
have
exactly why we brought this in this meeting. So think about it. Previously, when we said it's definitely not to be done, and now we are saying that
May I say something,
sometimes
please?
it could be done. Let's move on.
May I say something, please?
Who's this?
From the
Oh yeah, of course.
this is one point I want to make, that all these new trials which give prophylactic IMN, they contour a bit differently. They give lesser margins, so maybe we should also look at that. It's not 5 mm, it's 3 mm, and directly
Like a
to the
tongue,
vessels.
So, I'm just being double devil's advocate now and saying that we've just completed a feasibility of study of doing a VATS thoracoscopic internal mammary chain dissection of first to fourth space as a prophylactic measure. It's a feasibility study, and two such previous feasibility studies have been shown from China and Korea and other such places, this part of the world, which have shown that it's feasible, and we don't irradiate, we may not have any heart complication.
And
At
time
the
to
most, we may-
reinvent IMC breaking.
No, what is the yield of these your study?
I also wanted to say that there are papers which suggest to use VMAT for IMN radiation.
Yeah,
So
there
that
are,
is,
of
yeah,
course.
so
Yeah, of
that's
course.
also
I
a
think
technique we can adopt
The
more and
important
more.
question here again is the benefit that we see is in systemic recurrences and not in regional
Yeah, of
recurrences.
course. Yes.
So whether just removing the IMN nodes
It
by
does.
VATS is
So
going
that is,
to
if
have
you-
the same impact on
Sir,
system.
if you read the paper, it actually very clearly says that IMN radiotherapy does not only look at local control. It is a site through which there can be a conduit towards distant metastases, and you are irradiating that. So, I think we've had a lot of discussion on this. Ponder your thoughts. Think whether you want to change practice. Moving on. Yeah.
Okay. So sound trial was for avoiding axillary surgery altogether, and they have shown that there is no distant disease-free survival disadvantage or disease-free survival or overall survival if you do it in a selected group of patients. So to the surgeons on the panel, is it practice changing? If yes, which group? If no, why?
So the study itself, the median tumor size is about a centimeter or so. So I think you're dependent on your radiologist having very good accuracy of picking up the lymph nodes and being sure. In practice, we've all seen that's about 70 to 80% with really good radiology also. There are factors that you're going to pick up. You're going to pick up micrometastatic disease. Then you come to the other argument, which is add radiotherapy don't add radiotherapy, operate. So I don't think this is as simple. Yes, if you have an older patient, if you have someone with a screen detected T1AB tumor, if you have someone whose probability of having sentinel nodes positive, that is someone not in the central quadrant, probably in the medial quadrant, could you consider this? Yes, this is an option, but have I changed practice with this? The answer is no.
Dr. Goel.
No, I think mostly I agree with Neeta. So in, I think the West, about 70-75% of patients are firstly screen detected. And secondly, the quality of breast imaging, breast ultrasound, which is done prior to a patient coming to surgery itself is not widely available in our country. So overall, maybe 1% of our patients might be.
So will you do that for that 1% or no?
So as of now, I'm not really very keen to change for that.
Dr. Sheila.
For that 1%, I'll do it.
You'll do. Dr.
Screen
Lakshmi.
detected old elderly patient.
My thought is, it's actually a query I had. So suppose you get a patient, which we do many times, where a lumpectomy has been done outside and they've come to you. Margins are negative and it's a small size. They have done some imaging and the nodes are negative. In those patients, so in our center, we do offer them, we can do a sentinel node. And we have gotten the sentinel node also. It's not that you don't get the node. You get the node and it does set up negative many of the times. So in those patients, I'm very interested in using this study so they don't have to do a second surgery, because at the end of the day, sentinel node
Provided
is very...
you believe the other sonologist.
That we have a practice of repeating the imaging in our center.
But then
an
post
MRI.
lumpectomy imaging has its own fallacies.
We do an MRI.
Dr. Dalal.
And then,
yes, Dr. Dalal.
Yeah, so I would probably not change my practice. I usually would do a axillary sentinel sample rather than just a single node. So that generally is representative enough.
Let him complete.
Yeah. So basically that is sample enough, and if we get 4 to 5 nodes in that, and if only 1 or 2 is positive in that, it doesn't really change the further practice.
So what I'm hearing from all the surgeons on the panel is that they have not changed practice because this study was not quite representative of the kind of patients that we see in India. But increasingly, I think everyone will acknowledge that we are getting screen detected cancers, smaller cancers. Also, our radiology imaging is also getting better and better, and it is top class in certain institutions. The question is that if all of those conditions are satisfied, and it is not 1%, it will be more than 1%. So then would one believe in the results
So
of this study?
some of the surgeons did agree that they will follow if those patients fall in that particular group, and the authors themselves, although they included all the patients, all IHC group patients, they said they would recommend it for postmenopausal lady less than 2 centimeters, ERPR positive, HER2 negative cases
I mean,
only.
postmenopausal less than 2 centimeters, ERPR positive and HER2 negative is not 1%. That's what I'm trying to say.
It's almost 25%.
So, it's not 1%.
In their practice, or across the world, it is around 25%. But in our practice, probably 10%. Yes, I agree.
So my question is that do we believe scientifically, do we believe the results of the study? Are the surgeons willing to say that they may not have a role in the axilla in a certain proportion of patients, or will they say that I don't believe it, therefore this and that?
Surgeons are divided just like radiation oncologists were divided for IME.
So one thing is that they don't mention in these studies how many were screen detected, and we know that there is a length time bias of the screen detected tumors. They have a better biology. I wish they had mentioned in the paper how many are actually screen detected, but the palpable clinical ones maybe are at a higher risk.
The axilla is treated not only by surgery. The axilla is also treated by hormone therapy. It is also treated by chemotherapy, and it is also some bit of radiation also gets to the axilla. So surgeons are not the only ones who are treating the axilla, and that is what I think everybody has to appreciate.
Dr. Sudeep, there's something I would just like to say. One thing is that, say, it happened with Z11 also. The patient population of Z11 was very well defined, but the application of those results has actually gone way beyond what was the study population. That is there. Secondly, I still remember there was a publication few years back in NEJM, PAN et al. Hormone receptor positive breast cancer, after 5 years of endocrine treatment, the annual recurrence rates were more than 1% for without tapering off. Now these being more lower risk than that, so we really don't know what is going to happen over next 10 or 15 years. So what I would say is we should be a little more careful about sort of jumping to this, seeing the patient profile that we have in our country.
So there are certain cautions. Although it is a well-conducted study, the accrual was stopped before prematurely because most of them started following Z11 protocols. Although accrual was short only by 50-60 patients. As we have already discussed, ultrasound is a challenge. Quality of life also needs an assessment, but the numbers were not, and it was not a primary endpoint. Now, longer follow-up is needed because this is a very favorable biological group that they are recommending avoiding axillary surgery on. So 5 year may not be enough to show the recurrences and overall survival. Thankfully, there are multiple trials studying the same or studying the same question, and we hope that it will either more strengthen the data or even expand the indications in future. So we move on to the other meta-analysis, which was overview of axillary treatment, again from EBC to CG. They said that axillary recurrences are halved with more surgery, though they are rare as a whole. So there was comparison between axillary dissection versus radiation to axilla. However, they also said that axillary surgery leads to more lymphedema. We all know that. And Amaros trial, Dr. Dodul did mention that quality of life is significantly worse with surgery, but it is not. Lymphedema is worse. Quality of life was not. Long-term regional recurrence following RT versus ALND. Comments from the panelists. Can we start from the other side, Dr. Dalal?
In my practice, I think that basically most patients will have axillary node dissection, not necessarily so much of, especially with a large volume of nodes. If it's N1, it's a limited node dissection. If it's more than N1, it's a full node dissection. Radiation only for the axilla, I don't think I have had too many patients who have had only radiation for the axilla.
So Amaros also showed almost double axillary recurrence rates.
I think exactly
post
the
radiation.
same. And when they talk about the axillary recurrence rates, they omit hazard ratio there. They are talking of other comparisons with hazard ratio, only the absolute figures are mentioned somehow, whether it's an intentional omission or something, because it's almost double.
Dr. Tabassum, and then we move on to the next.
So if you, even if the recurrence rates are double, but it's just 1.8%, I mean,
So
what is the figure that we should be concerned about? That is the thing we have to.
So I'll hand over to Sanjoy for Amaros discussion, and we also need to discuss about second malignancies post RT, which probably we'll do in this.
So I just have one comment regarding the axillary lymph node dissection for number of nodes. I think in this entire analysis, yes, they have divided it in the forest plot as N1, N2, and N3, but the median number of nodal positivity in the positive node patients we see is 3. So when 1 to 2 nodes are positive, yes, there's an option of giving radiation versus doing axillary surgery. That's completely acceptable, I feel, in today's world. But when 3 nodes are positive, then if the median nodal positivity is 3 and you're going to have 4 or more, then we are questioning the therapeutic benefit of a complete ALND at this point, and that is probably not right.
Thank you, Shalaka.
Just one point. This is about Z11, which is quoted everywhere. But it becomes difficult to interpret because radiotherapy is such a mixed bag. 23% patients actually received axillary RT there, which was a protocol
I think
violation.
there was a paper follow-up by Reshma
More than
Jassy on
80%
it.
patients received RT with high tangents. So all such, such things are never discussed while discussing Z11.
Look, I think let us look at this in perspective again. So Amaros, de-escalation, the question, and I think to this we may actually have a consensus answer by the time we get out. We're looking at small tumors, T1, small T2s. We're looking at tumors that are ER positive. And like all our panelists are saying, we're looking at a less positive burden in central lymph node. Yeah? And in this group of patients, the question is whether your surgeon goes back for a second look surgery and does an axillary dissection, or whether the radiation oncologist, while he or she is treating the breast or the chest wall, is good enough to give radiotherapy to the axilla. And to this, I think Amaros at 10 years is saying that, look, the axillary recurrence is low anyway. And like Sir was saying, they're not giving a hazards ratio, and there's a reason for it. So if there's 1 versus 2 recurrence, the hazard ratio is going to be 2. But that doesn't mean, it's alarmingly high. Like Tabassum was saying, that doesn't mean that it's oh God, the hazard ratio is 2. When the overall local recurrence in the axilla is just 7 out of 744, or 11 out of 681, the inherent rate of local recurrence in these groups, even after sentinel lymph node positivity, is low. Let's agree on that. And then if it is low, if you give radiotherapy, you do not have lymphedema as much as you do if you have surgery. So under these circumstances, and I'm again being provocative because I want you to guide the discussion, why would you actually go back and give an axillary nodal dissection in these group of patients and not go for surgery and treatment of axilla 1, 2, and 3 level nodes? Open to my colleagues. Because that is what the evidence is. We don't have a no radiation arm over here at 10 years follow-up. So if we do, yeah, of course there are trials on it. Of course there are trials on it. Yeah.
So one thing is that a lot of centers in this country, in our country especially, do use frozen section, where you may not have the complete picture. So some of our pathologists will tell us, okay, there are 3 out of 5, we have looked at all of them, there are 3 out of 8. But we often get when one node is positive, they stop looking at it first.
Shalaka, we're not looking at frozen section. We're looking at, say, if someone's sentinel node definite positive, 1 or 2 nodes positive, would you actually be alarmed if your radiation oncologist said, no, look, I would treat the level 1, 2, and 3?
So if I think if radiation can be given, then it may be okay.
Of course, sir.
Yeah. So I'm just going to say one thing.
So your time is up and there is a voting.
Okay. So I'm just going to make one comment.
Voting has to be done.
So I'm just going to make one comment before I hand over to Sir. I don't think we look at just one node. I think most of us look at lymph node ratio. We look at the size of the met. We look at multiple factors before we decide surgery versus radiation.
So you could. So what you're saying in a group, you could. Okay, sir, concluding remarks.
So are there any more slides you have? Just
sir, I think going through the other slides, they're mainly on genomic profiling.
So we have 5 questions, and after that your comments. So we have 10 more minutes left total.
Oh, 10 minutes?
10 minutes left, 5 minutes for you and 5, no, that was only
So
for the
10
panel
minutes
part.
at the expense of the tea break. So then whoever wants to have tea can go out and come back. I will start the next session at 11. So
those 30 minutes were only for the panel.
Finally, we're coming to the genomic profiling. Less number of patients in our country would possibly benefit. We heard that if you do oncotype DX in a favorable group, 1 centimeter median tumor size, and do oncotype DX along with the tumor biology, you may actually spare further axillary.
Sorry, I have to ask a question here. This is to any radiation oncologist on the team because I have discussed this with Vinita. We are struggling with getting our radiation oncologists to accept fast and fast forward. We are now discussing omission with more comfort.
No, your radiation oncologists are safe, so they're waiting for the hypoadjuvant study to report. That's why they.
Yeah. So the thing is, but we're willing to discuss the option of no radiation.
So let's just move on. I think these are again certain genomic risk scores that can be done to.
There was just one comment about the IDEA study. Interestingly, in 5 years, no distant recurrences were reported in that study, while no. 6 or 7 local regional recurrences have been reported. No, survival was 100% breast cancer specific and no distant recurrences were there, I noticed. What I'm saying is generally you say that distant recurrences have to be usually higher than local regional recurrences. So probably in some way the local regional treatment was suboptimal. Again, the impact is not there on survival. So we are reaching a stage in breast cancer where showing an impact on survival is going to be sort of difficult in most of the low risk.
So we'll now move on to the questions for another 10 seconds on this. ARM study was done and they found...
As chairpersons, we will now take over last
Okay.
5 minutes. Okay, thank you very much.
Can we go to the questions?
No, I'll do that.
Okay.
So what are the questions, please? Have the questions come to you?
Yeah, the first question
Okay. So mammographic surveillance, more than 55 years. Every year. So now the voting, please.
Voting
Number
for the
1.
First question.
You've done? Well, in 5 minutes you will say session is over, now close. Okay. Okay, so we have got every year. Still most people believe it is every year. I think we don't have time for comments for each question, no? So otherwise we won't be able to summarize everything. So the number two, question number two, 60 years postmenopausal lady, 1.5 centimeter, grade 2. I think everyone can read, so people can read and then. That's a timer. Okay, almost near unanimous. Good. Interesting. Okay, outlier. So number three, question number three. Okay,
Oh.
good. House is divided.
Good numbers
Good.
for bilateral. So,
Good.
so you are going to tell the patient.
You
Right,
will come
for
to that.
bilateral. Good.
So next, please, number four. Okay, a lot of people want to irradiate IMN. The last question. The last question. Okay, so a lot of them people want to wait for this, but you see the number of people who have voted. It's not a lot. Only about 40 people have voted.
40 people, fantastic.
No, but there are more than 100 people in the crowd. So I think we have last few minutes, isn't it? We'll just so I will just briefly talk
Thank
about.
you. Yeah.
Thank you very much. I think both the moderators really brought out a lot of controversy, and the participants, the audience was also very animated and they raised their points. And thank you, Anushil, for being yourself, being Anushil. So I'll very briefly talk about two aspects. One is the last bit we discussed about radiation for the adjuvant radiotherapy. I think sometimes we do not know what will benefit, but we know what will harm. So in adjuvant radiotherapy, there are two things which actually harm. When we irradiate an axilla which has been dissected or cleared, we know that increases the lymphedema rate very substantially. So don't get fooled by the MROs because that was only after sentinel node biopsy. And the other is when we treat IMN, by whichever method we treat, IMN radiotherapy adds to the morbidity and perhaps mortality. The previous study showed it added to mortality. Now probably we are not sure, but we treat a very tiny sliver of tissue. I don't know whether we are actually treating IMN properly or not. Even that, as Vinita said, the dose to the contralateral breast and heart and lung increases. So for both those areas, I have to have a compelling reason or a data to go ahead and give my radiation. Of course, we know the techniques are safer. So, and the data which was shown in the meta-analysis, I think those will presented very well, the dissected out. There was only one study where it was Iman alone. Rest of the contribution of RNA comes from supraclav and axilla. So I think that's where I think we need to have a finer balance. That is for regional nodal irradiation. MRO study, I think it showed that if you give radiation, and because you are already giving radiotherapy, just basically modifying a field a little bit and you covering axilla, we know that it is not adding to morbidity, and lymphedema rates are much less. Now the second bit I will very briefly talk about is the BRCA mutation contralateral mastectomy. Earlier, it used to be more of an academic discussion. Most of the time, by the time they had the genetic test report, surgery would have been done, and then some of them already received radiotherapy. So only the ones who are very keen to have contralateral breast, or the surgeons who are very keen, they would go. Now they have the BRCA report while they are on neoadjuvant chemotherapy and surgery has not happened. So then this becomes a real discussion. They actually have an option. And so, like in our practice, we see lots of such patients. So those who would have other had ipsilateral therapeutic mastectomy, contralateral prophylactic mastectomy, some of them who are T1, T2, N0, they would not require radiotherapy. And the reconstruction option also at the same setting, reconstructing both the breasts is, as I understand from my surgeons, is much easier than doing one now and one after 3 years. So these are my comments and my co-chairs.
Yeah, I think first, thank you, the organizers. I think for having two sessions on local regional. I think that's a wonderful thing. We really had a wonderful. All the presenters presented well. I think wonderful also moderation by both Sanjoy and Vedant. I think I really learned a lot, and it was really useful. And I remember the time, like, when in earlier TMS we used to treat the IMN with brachytherapy, So in fact, it was the surgeons who actually placed the brachytherapy catheters in the internal mammary vessels, and then the radiation used to happen. So I'm happy to see a lot of controversy has happened since then, and maybe there is still a role for surgeons to place IMN brachytherapy, or possibly VATS resection, as Chalaka said, So I think that's one thing that I wanted to say. The other thing is about the AMARAS trial, with more amount of recurrences, second primary cancers is something. Yeah, I think that is something that nobody really talks about. So that's something that maybe we can have it for another day. But again, these are the two small points. I had multiple other points, but in the interest of time, I would like to sort of thank everybody, thank the panelists also. Thank you, organizers.